My name is Rod Mkenzie. I'm going to talk to you about damage control resuscitation in the pre-hospital phase of care. I am a consultant emergency physician based in the United Kingdom, and if you're not really familiar with UK emergency medicine training, please feel free to look at the Royal College of Emergency Medicine website. One element of emergency medicine training in the UK is, of course, pre-hospital emergency medicine subspecialty training, and that's a subspecialty area of practice for not just emergency medicine, but intensive care medicine and anaesthetics. I'm based in Cambridge in the east of England. Cambridge and the east of England is north and to the east of London, an area of 6 million population with a geography of about 20,000 square kilometres. We have a very sophisticated trauma system in the region with 12 acute hospital trauma units, a single regional major trauma centre at Cambridge, and a network of a regional ambulance service and 5 air ambulance providers, which have physician-staffed pre-hospital emergency medical teams on them. And we receive roughly 1,700 to 1,800 patients a year in total within our system. And as you'll see from this slide, we have a holistic approach to the system. Our pre-hospital phase of care is just as important to us, particularly with our dispersed geography as the hospital phase of care. And here's the sort of activity that we undertake in the trauma centre. And obviously there's a lot of activity happens both pre-hospitally and in the trauma units. And we like to think of ourselves as a single integrated whole of pre-hospital and hospital-based providers. Now, we teach damage control resuscitation principles for our hospital staff and for pre-hospital staff. And if you're interested in one of our whole day seminars or courses, then here is the link here. We normally spend a whole day talking about this, and I'm only going to spend a few minutes talking about it. So please forgive me if I'm moving quite quickly through some of the concepts that I want to share with you. If there's one slide to take away, this is it. This is the overarching principles of a damage control resuscitation philosophy. And we will go through this slide and break it down and talk briefly about every element here as they apply to pre-hospital phase of care. The fundamental principle of damage control is, of course, recognizing that no therapy, nothing we do comes without risk. And that's especially the case in undifferentiated pre-hospital patients who have deranged physiology. We often think about this chain of survival, and we often think of, the chain is only as strong as the weakest link, and sometimes pre-hospital emergency care is a weak link, but we want to strengthen that link by understanding how we can apply the principles, if we can apply the principles we use in the emergency department and trauma center setting to some of the pre-hospital phases of care. And that's where this philosophy of damage control, we think can be applied out of hospital. So in our chain of survival in our region, and you can see that the pre-hospital phase of care is really integrated with everything else that goes on. The care of our trauma patients doesn't start in the emergency department. It starts in the pre-hospital phase. And as I've shown you, there's some details that you can look up around how our network works in more detail. The concept of damage control, of course, like with many aspects of trauma care, has its origins in warfare and fighting and military operations. And really from naval operations, where if a ship, a fighting ship, a warship is damaged, the priorities are to continue to fight whilst keeping the ship afloat, be able to move to safe waters, and then only undertake full repair and reconstruction later on. And you can see the analogy straight away with how we might think about applying this to a trauma patient. Our surgical colleagues have, of course, been talking about damage control surgical approaches really for many years now, in terms of thinking about doing the minimum necessary to keep the ship floating, stabilize the patient, and plan for definitive surgery at a later stage. Of course, it's also been recognized that, to quote Nicholas Sen, the fate of the wounded rests in the hands of the one who applies the first dressing. And that's a philosophical approach that we think is very important. Damage control surgery, of course, has this idea of 3 phases: the early laparotomy in the context of abdominal trauma, followed by stabilization, followed by definitive repair. And for many people, it was quite a a shift to start to think of surgical intervention in these ways. This is the sort of patient where a damage control surgical approach is obvious and immediate, and none of us would doubt that. And the damage control surgery thinking has, of course, evolved in recent years to not just think about those three parts of damage control, but to think about another part before the patient gets to the operating theatre. So recognition, considering the role of a permissive hypotensive strategy, whether or not fluid replacement is indicated and with what fluid, and thinking about coagulopathy. So our surgical colleagues have been thinking about damage control in the ED and damage control pre-arrival in the operating theatre. So we want to apply the same kind of thinking to these patients, and these patients are at least an hour away from us, sometimes more than an hour away from us, yet their clock has already started in terms of their injury risk. So our big challenge was to consider whether or not the same principles that are used for damage control surgery and damage control resuscitation more broadly would apply in the pre-hospital phase of care. And we approach this by thinking, what is it that we do that could cause harm, and should we challenge some of the historical thinking around the way things might be done to reduce the risk of harm? So returning to the slide, the picture, the damage control resuscitation picture, if we think about our resuscitation room and we think about all of that equipment and all of those things, this is one of our trauma bays in Cambridge, then of course we can start to see how we want to replicate elements of this in a safe and appropriate and efficient way in the pre-hospital phase. Central to damage control is this idea of one-way progression to pre-hospital damage control and ED damage control. Patients don't stay where they lie. This isn't their definitive endpoint. So everything we do is considering what the endpoint is and how we're going to get there as safely as possible. Obviously, primary assessment, primary survey, and immediate life support is not something I'm going to talk about in detail today. There's an assumption that whatever particular program pre-hospital services follow, whether it's ATLS or ETC or the pre-hospital derivatives of these, that there is a meticulous attention to detail around the basics. Okay, I'm bringing the basic ABC or CABC of pre-hospital care. That's not damage control, that's bread and butter. That's a sort of phrase that indicates it's the simple, straightforward, easy to apply principles of trauma life support. Damage control philosophy is about, after the primary assessment, once we've addressed immediate threats to life, considering which, if any, damage control strategy is applicable to the patient and how that strategy might balance against other strategies which might cause harm or risk harm, and how those strategies can be applied safely and appropriately. And of course, in the pre-hospital phase, we need to be thinking about that destination and determining, based on how the patient responds to our damage control strategy, determining where the patient goes, this sort of pre-hospital triage in terms of destination hospital, and thinking also what they're likely to need in the hospital setting, whether that be surgical intervention or imaging or interventional radiology or critical care, or a combination of all of them. And all of this happens whilst the patient is in transit. So the patient is moving throughout this whole phase and against the clock. So no small challenge to think about these damage control strategies and how they might apply to our pre-hospital patients. So damage control isn't, in our view, just about the abdomen. It isn't just about surgery. And actually, you're seeing, hopefully, from the slide, it's not really just about bleeding. We really talk about damage control resuscitation being about minimizing further injury, optimizing physiology, maintaining tempo, by combining really basic resuscitative interventions with deliberate, focused, and specific damage control strategies relevant to the injury pattern and pathophysiology. So if we start to think about each of these strategies, and I'm just going to go really quite quickly through these and what we mean by these, and I'm happy to engage in some dialogue at some stage with anyone who's watching this to discuss things further. Again, return to what we would do in the resuscitation room setting in terms of preparation. We need to be planning to care for patients in the way that we're used to caring for patients. So we can recreate and reproduce the environment in which we work to optimize the safety of care and allow us to focus on the philosophy of damage control rather than the logistics of where things are. We use all sorts of tools in the emergency department setting to optimize safety and optimize care, and we can use those in the pre-hospital setting as well. We're used to seeing people in the particular in the anatomical position, ready for us to encircle them and provide that structured team-based care. So actually in the pre-hospital phase, we can do the same thing. We don't need to care for this person in this position. We can actually do some interventions early on at the stage or just after the primary survey, with or without the benefit of procedural sedation, to get the patient into a position in which we can now be more familiar with and more comfortable with managing. Our airway management approaches and principles are essentially the same as other speakers will talk about. I'm not going to dwell on some of the airway management challenges around pre-hospital care. And similarly, in terms of thinking about breathing, or the key issue in damage control resuscitation is actually about this idea of a lung protective strategy. Once our lethal 6 has been identified in the primary assessment, we've considered the hidden 6, or so-called hidden 6, and then we're thinking about lung protective ventilation strategies. So here is a kind of really simple reminder. I'm not going to talk about ventilation strategies in detail of when we're considering ventilating patients in the pre-hospital phase. And again, the same sorts of principles apply in the hospital phase as the pre-hospital phase. We're trying to identify patients who would benefit from oxygenation and ventilation. We want to reduce metabolic demand, and we want to maybe support some of the other strategies. So a lung protective ventilation strategy, safe and effective, consistent airway management may be appropriate for our patient. There may not be once we've completed a primary assessment, but we want to make deliberate decisions. If we're going to ventilate someone, we don't want to harm them with, in terms of volume or pressure damage. The injured lung is like a baby's lung, I often say, in terms of thinking around a lung protective ventilation strategy. And that's often something we've found isn't necessarily considered in the pre-hospital phase. Now, many people, when they talk about damage control, are really talking or mostly talking about bleeding. And there are two damage control philosophical approaches or strategies, if you like, related to bleeding that are very important. One is this idea of hemostatic resuscitation, and the other is this idea of permissive hypotensive strategy. And I deliberately separate the two here because they're, in many respects, quite different. We know we need to stop the bleeding, we need to gain access to the circulation, we need to think about and manage coagulopathy, maintain perfusion, and if necessary, think about restoring volume. We know all of those things. We don't want to lose any blood if we can help it. And all of the things that we would do in the emergency department setting, we can do in the pre-hospital setting. We can apply exactly the same principles that are listed on this slide in terms of compressible and non-compressible bleeding, thinking about, again, coagulopathy and the approaches we can do to reduce coagulopathy, and considering, of course, the risks and benefits of transfusion. In the pre-hospital setting, that might be giving blood if it's available or blood products, but it might also be considering activation of massive blood loss protocols in the receiving hospitals. This escalator of interventions you're all familiar with. We would do that exactly the same way in the pre-hospital setting, and increasingly the equipment that's used in the pre-hospital setting is exactly the same equipment that we would be using in the emergency department setting, whether that's pelvic binders or Kendrick traction devices, or whether it's the hemostatic agents that are available in the market to think about wound management and control. You all know about that lethal triad of acidosis, hypothermia, and coagulopathy, and the detrimental effect. And thinking about coagulopathy, excuse me, is very important in a damage control approach, because we now know that trauma-induced coagulopathy is present in more patients than we thought about before. So if we assume it's present and think about all of the things that will minimize further coagulopathy or the risk of coagulopathy and do something about it. And so from a pre-hospital setting, we're talking about avoiding anything that's known to exacerbate coagulopathy and bleeding, and create the physiological conditions that actively facilitate clotting and minimize tissue ischemia. I like the quote, "Give no fluids that do not clot or carry oxygen." I think that's a useful kind of mantra. Now, this idea of a damage control bundle in the hospital setting is well published, and increasingly we're starting to articulate what the pre-hospital bundle, or the integrated bundle, as I'd like to say, might look like. So that's this idea of hemostatic resuscitation, of stopping bleeding and replacing volume and managing coagulopathy. Permissive hypotension is a slightly different subject, and it goes by a number of different names, but they all refer to the same concept of avoiding over-resuscitation until definitive hemorrhage control is established. Shock is bad for you, and permissive hypertension is allowing the shocked patient to remain shocked as a bridge to an intervention to control bleeding. So it's not a therapeutic intervention in its own right. It is not doing something as a bridge to controlling bleeding. And I think that's a really key point. It can be incredibly dangerous in some patients, and in children, it is something which is only applicable to a very small subset of patients with active exsanguination, which is uncontrolled, where fluid resuscitation, or it may in fact be counterproductive, if not futile. And there are lots of guidelines and recommendations regarding what the patient may benefit from in terms of very small volumes of balanced resuscitation, again related to the time of injury and the time that they've been in a shock state. And this idea of a balance in terms of allowing the shocked patient to remain shocked, recognizing that is causing harm, but at the same time also recognizing that if you try and restore normality, if, for example, to maintain perfusion of vital organs, that you might also be causing harm. So this is a really difficult thing to be thinking about, and a complex area to be thinking about, but it's really important to consider it separately from hemostatic resuscitation. And of course, permissive hypertension in the context of traumatic brain injury may in fact be very bad indeed for our patients. And that leads me on to this idea of a neuroprotective strategy. And you will see immediately a conflict here in this row of possible strategies, that one may offset the other. When we talk about neuroprotection, we're not talking about primary brain injury. We're talking about all of the things that happen after the initial primary injury, which we know are harmful to the brain, the things we can do something about related to what I sometimes refer to as the 4 H's: hypoxia, hypotension, hyper or hypocapnia, and hypothermia. We know that if we can manage these 4 H's, that we can reduce the harm or the risk of secondary brain injury. And again, there are a number of target values that have been published related to the sorts of things we could be thinking about doing to protect the brain and indeed protect the spine from further injury. Deliberate, meticulous attention to detail to achieve these things if appropriate. Wound protection is often ignored. These are wounds that may result in overwhelming infection, that they're not just limb-threatening, but life-threatening. And there's a whole bunch of things that we could be thinking around, not just around a hemostatic resuscitation and controlling bleeding, but also about how we protect the wound, protect the patient, protect tissue, administer antibiotics in the pre-hospital phase, and so on. None of the things I've said are particularly controversial or new. Some of the things I've talked about, particularly permissive hypertensive strategy, clearly wouldn't necessarily apply to children, and that's a kind of a health warning that goes with thinking about damage control resuscitation. I just want to make that clear to you. I've really zipped through really quite quickly this damage control resuscitation approach and how we believe it can be integrated between the pre-hospital and the hospital phases of care. I'm very happy to enter into any dialogue with anyone who wants to discuss that with me or raise any particular questions. I hope that's been a useful summary and overview of what damage control resuscitation might look like in the pre-hospital phase and the sorts of things that we consider when we're talking about a damage control strategy. Thanks very much for listening. I hope you'll enjoy the rest of the conference and maybe catch up with some of you soon. Bye-bye.